Hi, I'm Ziad Obermeyer. I'm an associate professor at Berkeley, and I'm going to draw on some of my research on algorithmic bias to learn something about bias in humans, and specifically in how we as a society have responded to the COVID-19 pandemic. So this story is about how good intentions can go wrong. Like the rest of us, our legislators wanted to do something positive for our health system as it strained under the burden of COVID. And so the CARES Act and the Paycheck Protection Act together released $175 billion to support hospitals and providers and other entities in our healthcare system. And that's great, but it turns out you can't just give $175 billion out. You have to decide how and to whom and where and when. So there's a precedent in our healthcare system for how we allocate relief funding. And it's the way we give it in a lot of other programs, including the Medicare Disproportionate Share Hospital Program, drug rebate programs, and several others. And that's to do it in proportion to revenue. So that seems natural because the bigger the hospital, the more patients it has, most likely the more COVID-19 patients it's going to have. And it also correlates to a lot of other things we might care about. So the number of elective surgeries that hospital had to cancel because of COVID. So that makes sense on a lot of levels. And that's exactly what's happening now. So that's how this money is being given out as we speak. As you can imagine, some hospitals were happier about this than others. So the big hospitals were very happy because they were getting a lot of relief money. But there were some other hospitals, other types of hospitals, that were also quite happy about this. For example, the rich ones, the profitable ones, the ones that engage in some behavior that we don't always like. For example, overuse and upcoding. The ones that are in very consolidated markets where they can get away with charging higher prices. And that's the big problem with this way of giving out relief funding. The rich get richer. So if you think about which hospitals are getting more money, it's the ones that bring in a lot of revenue. Now, sometimes that correlates with things that we really want to give relief funding in proportion to, but sometimes it doesn't. And there's a corollary to this. So if you think about the kinds of hospitals who might need a lot of relief funding, but don't have a lot of revenue to show for it, who are those hospitals? Where are they? And who are they serving? Well, they are serving non-white and minority patients because those patients generate less revenue for the hospital. They come to the hospital less because they mistrust providers more. They have less access and less insurance to pay for the care. And all of those factors that mean that disadvantaged patients get less care when they need it means that the hospitals serving those patients are getting totally screwed by this way of allocating relief funding. They're the hardest hit by COVID, but the least likely to get help by the government, while the rich hospitals just get richer. Talk about building trust. We are supposed to be in the business of helping people who need it. That's what the public is entrusting us to do as a healthcare system. We're supposed to be in the business of health. But very often we confuse that health with other things that are easier to measure. For example, dollars. We do this pretty consistently in a lot of different ways. We use income to measure the value of a life year. And we do that both because we often think about value in terms of dollars, but also because it's hard to measure what matters. Things like health or health needs or sickness are actually really hard to measure consistency, whereas dollars are not. But the last thing this country needs is the health system, which is charged with protecting people who are sick and weak, to start measuring their worth by how many dollars they bring in revenue. So most of my own work is about algorithms, and this story sounded very familiar to me. Last year in work we published in Science, we found that an algorithm that was being used to make decisions for 70 million people every year in the US was massively biased against Black patients for this exact same reason. The algorithm conflated healthcare costs with healthcare needs and ended up meaning that Black patients were prioritized lower than healthier white patients because of lack of access to care and discrimination translating into lower healthcare costs, conditional on healthcare need. Now, the end of our story was actually optimistic. We worked with the company that made that algorithm to fix the bias. And on one measure of bias, we reduced it by 84%. We're working with a bunch of healthcare systems, insurers, and software developers now to make sure that that doesn't happen again. When we fixed that algorithm, it was like flipping a switch. We found the problem, we retrained the algorithm, and we fixed the problem. But how do you fix human bias? Bias in our laws, bias in our healthcare system, bias in the way we think about the value of someone's life. So here's one insight from fixing algorithms. How did we fix the bias in that exercise? Well, we actually just told it to predict, instead of predicting how much someone is going to cost next year, we asked it to predict measures of health. And what measures of health did we use? Well, that was the hard part. We put together a lot of diagnostic codes, labs, and vital signs. And we did that because health is complicated and multidimensional, and it's hard to measure. But it's worth it. Measuring things right is the way to make sure that algorithms are going to get resources to the people who need it. And it also means that we're going to target our policies better by delivering relief funding to people who actually need it. So what does that mean for humans and for human policies? Well, we should stop using healthcare costs as a measure of healthcare needs everywhere, not just when we're allocating COVID relief, but when we're allocating population health management resources or anything else we're doing in the health system. We have incredibly rich population-based surveys that give us fine-grained measures of health at the county level. We have rich data on COVID impact, cases and test positive rates, overall mortality during the pandemic. Even if we don't diagnose COVID itself, we can see where mortality is increasing. And we have all sorts of data measuring how much resource hospitals need, how much relief we should give them, which is not the same as how much revenue they bring in. In summary, health is not measured in dollars. And if we can remember that, we'll have gone an enormous way to making funding more effective, to making better algorithms, and to reducing bias. Thank you.